Good afternoon, ma'am. I am your radiologic technologist for today, and my name is JONALD. Mawatanan ako, ma'am, if kasi pangalan sa patient, ma'am.
Kinshin. Sis.
Ma'am, unsa ni unsa yung mga examination ani, ma'am?
Chest and skull x-ray.
Sige, okay. Then, ma'am, so before nato siya i-x-ray o i-x-ray, please pakitanggal good sa ilang mga metallic objects, ma'am, like mga areoles or anything na metals. And ma'am, naabot yung patient's gown. So, dito, if ever, pwede na po siya mag patient's gown. And in today's video, we're going to demonstrate the PHS of the pediatric patient, and as well as the skull series of a pediatric patient. So, first is we're going to demonstrate the PHS of a pediatric patient. In patient positioning, position the patient with it's either erect or seated. Since our patient is a pediatric, so it's much better to use the seated positioning. So, patient is placed on seat with legs down through the center of the opening. As you can see, the patient is seated. Then adjust the seat to the correct height so that the top of the IR is about 1 inch or 2.5 centimeter above the shoulders. Then the arms are raised, and the body will be perpendicular, or the chest will be perpendicular to the IR, and the body clamps are placed firmly against the patient and secured by In today's video presentation, we're going to demonstrate the PHS of a pediatric and the skull series for pediatric patient. First is we're going to demonstrate the PHS for pediatric patient. Our patient for today is Mr. Ken Shin, and in patient positioning, the patient may be seated or standing erect. So for today's video, we're going to use the patient on a seated position because this is the most comfortable for our patient, for since he will going to have his PA chest x-ray. So in patient positioning, position the patient in seated with legs down through the center opening, and adjust the seat to correct the height so that the top of the IR is about 1 inch or 2.5 centimeter above the shoulders. So, and then the arms are raised and side by body clamps are placed firmly against the IR and against the patient, and are secured by base adjustment and adjustable step. So this is our step kunuhay, and lead shield is raised on the level about 1 inch above his iliac crest. So the correct right and left markers should be placed to the expose the lower image. So ensure that there is no rotation of the patient. So the central ray must be perpendicular to the IR at the level of the mid-lungs field of the patient. Then the recommended collimation would be collimate closely on the 4 sides to the outer chest margins. Then if the child is crying with respiration, and make expose as child by fully inhales and holds the breath. So we will going to instruct the patient that he will hold his breath before taking the exposure. Then the Again, the central ray must be perpendicular to the IR at the level of the mid-lungs field of the IR. So this will be our landmark at the thoracic 7 of the patient. So we're going to demonstrate the so that is our perpendicular the central ray must be perpendicular to the thoracic 7 of the patient. In PHS radiography or PHS X-ray, the IRUs must be a 10 by 12 inches since our patient is a pediatric or a child. So place the marker of the exposure at the level of this one so that the collimated area, below the collimated area, then
the action.
in evaluation criteria for PHS pediatric radiography, the anatomy demonstrated must be the interlung. The interlungs should be included from the apophysis from cervical 7 to thoracic 12 level to costophrenic angles. The airfield or the trachea from T1 to thoracic 1 down is demonstrated, as well as the hilum region markings, thymus, heart, and bone of thorax must be clearly demonstrated in this procedure. Chin is sufficiently elevated to prevent superimposition of the apophysis. There should be no rotation exist as the evidence by equal distance from the lateral rib margins on each sides to the spine, and distance from both sternoclavicular joints to the spine. And there should be a full inspiration visualizes the 9 to 10 posterior ribs above the diaphragm on most patients. So the collimation to the area of interest must be clearly demonstrated. So the lung contrast is sufficient to visualize the fine lung markings within the lungs. Faint outlines of ribs and vertebrae are visible through the heart and mediastinal structures. There should be no motion is present as evidenced by sharp outlines of the rib margins, diaphragm, and heart shadows.
Jen?
The next procedure will be the lateral chest for pediatric patients. So, in patient positioning, the patient is placed on seat and adjusted to the erect height so that the top of the IR is about 1 inch to 2.5 centimeter above the shoulders. So, have the patient to instruct that he will going to raise her arms upward and place the body firmly against the patient. So, sir, pakita sa imong kamot, sir. Dikit gamay, sir. Dili, sir. Then, the lid shield should be provided since our patient are pediatric, so his or her gonads are very sensitive and eyes are sensitive to radiation. So put some gonadal shields to the patient. Then ensure that in patient positioning there should be no rotation of the body parts that have been exposed, that will be exposing. Then the IR that we will going to use is 10 by 12 inches since our patient is a child. In lateral PA projection, if patient is already in position from the PA projection, the patient and are turned to 90 degrees to lateral position. So as you can see, our patient will be turned into 90 degrees. the lead shield remains in position and the lead marker is changed to indicate that the correct lateral IR is placed in the film and hold up the mount. The CR or the central ray must be perpendicular to the IR at the level of the thorax or the mammillary line. Then the minimum SID would be 72 inches or 183 centimeters. Same with the PA chest radiography, PA chest X-ray. So you can see, your hands will be okay. The central ray must be, again, the central ray must be perpendicular to the thoracic 7 of the patient. You can locate his thoracic 7 by palpating his inferior angle of his scapula. So this is the central ray must be perpendicular to the thoracic 7. So that will be the central ray must be placed. Then before exposing the patient, instruct the patient to hold his breath so that there should be a complete visualization of the lungs apices and the full expiration. So for anatomy evaluation or the evaluation criteria, the interlungs from the apices to the costophrenic angles and from the sternum anteriorly to posteriorly ribs are clearly demonstrated. Then chin and arms are elevated, so we elevated his arms so that to prevent excessive soft tissues from superimposing the apices. Then there should be no rotation that will exist on the radiograph. Then the bilateral posterior ribs and costophrenic angles are superimposed. Then the collimation to area of interest must be correctly demonstrated. Then there should be no rotation that is evident by sharp outline of diaphragm, rib borders, and lung markings. Then the exposure is sufficiently in order to visualize a firmly rib outlines and lung markings through the heart, shadow, and upper lung region without overexposing other regions of the lungs. So we need to put the marking so that we will know that the radiograph, the resultant radiograph is in lateral position. That's one mark. In today's video, we're going to demonstrate the pediatric skull series, which are the AP reverse Caldwell, and AP Towns procedure, and including the lateral projection of the skull. So first is we're going to demonstrate the AP reverse Caldwell, and AP Towns projection. So the IRUs that the image receptor that we're going to use is for pediatric patients, we're going to use the 10 by 12 inches IR. So the clinical indications for this procedure is fractures, congenital anomalies of the cranium, including the sutures or fontanelles, head size, shunt checked, bony tumors, and other pathologies of the skull. So the technical factors that we're going to use are the minimum SID would be 40 inches or 102 centimeter. The RR size must be determined by the size of the body part to be radiographed. So then the IR must be in a lengthwise position. So today, so we're going use the IR size of 10 by 12 inches. So grid, if the patient's head is more than 10 centimeter, we're going to use a grid. Then the shortest exposure time possible must be used. Always remember that shield those radiosensitive tissues outside the region of interest, such as the patient's gonadals, because this part or the patient's gonads are very sensitive to radiation. So in patient positioning, since our patient is a pediatric, so we need to immobilize the patient. Then in patient positioning, the patient must be in a supine and align the midline of the table of the grid. So the head of the patient must be positioned at the midline of the table of the grid. So in part positioning, position the head with no rotation. Then as you can see, the patient is positioned in a supine position. Then adjust the chin so that the orbitomyata line or OML is perpendicular to the IR. Adjust the chin, so chin, that's the correct position. So in AP projection of the skull, so the center the central ray at the glabella of the patient. At the glabella of the patient. So that is our AP projection of the next for AP reverse Caldwell, the central ray must be 15 degrees cephalad to the OML. Cephalad to the OML. So that will be the central ray for AP reverse Caldwell, which is the central ray must be 15 degrees cephalad to the OML. The next one is the AP town projection. The central ray must be 30 degrees caudate to OML. Caudate to OML. So that will be our projection. The central ray must be positioned at the 30 degrees caudate to OML. The next one, so for recommended collimation for this procedure is to collimate closely on four sides to the outer margin of the skull. So note that generally holding by patient is not needed for examination of the head if immobilization devices are used. For evaluation criteria, the entire skull, including the cranial and facial bones, must be clearly demonstrated. No rotation occurs as evidenced by asymmetric orbits at equal distances from outer skull margins. For AP projection of the skull, the petrous ridges superimpose the superior orbital margins. For AP with 15 degrees cephalad angle, which is the AP reverse Caldwell, the anatomy must be the petrous pyramids and internal auditory canals are projected into the lower 1/2 to 1/3 of the orbits. For AP town with 30 degrees caudal angle, the petrous pyramid are projected below the inferior orbital rim, allowing the visualization of the interorbital margin. Then the dorsum cellae and posterior clinoids are projected into the foramen magnum. Collimation to the area of interest must be perfectly demonstrated. For exposure, no motion is present as evidenced by sharp margins of the bony structures. the penetration and exposures are sufficient to visualize the frontal bone and petrous pyramids through the orbits. So to summarize, for AP skull, the central ray must be perpendicular to the OML, which is the central ray must be centered at the glabella. So for AP projection, there should be a 0 degrees angle. So there will be no angulation for AP projection of the skull. For AP reverse Caldwell, there should be an angulation of 15 degrees cephalad. Then for AP town, the angulation must be 30 degrees caudal. The next procedure that we were going to demonstrate is the lateral skull position. So the clinical indications for this procedure are the same as shown in the AP projection on the AP projections, such as the AP projection of the skull, the AP reverse Caldwell, and the AP town projection. So the technical factors are the minimum SID will be 40 inches to 102 centimeter. The IR size and placement is determined by the size of the body part to be radiographed. Since our patient is a pediatric, so we need to use a smaller IR size. So specifically, we were going to use the 10 by 12 inches of 10 by 12 inches na IR. And if the patient head is greater than 10 centimeter, we will going to use a grid. Then the exposure time should be as shortest as possible. Then always remember to shield the radiosensitive tissues outside the region of interest, because, for example, the gonads of our patients are very sensitive to radiation. So in patient positioning, immobilization techniques should be used and necessary. Since our patient is pediatric, we need to use an immobilization technique. Then the patient is in semi-prone position centered to midline of the table. So the next is in part positioning. So the patient must be rotated in patient positioning. The patient must be in a semi-prone position. Tagilid dong. Tagilid po, sir. Anak. Tagilid. This is a semi-prone position, and make sure that the midline of the head of the patient must be centered at the midline of the table. Then in part positioning, rotate the head into the true lateral position and maintain position by placing a sponge or folded towel under the mandible. So the recommended collimation, the hand should be at the side of his body so that there will be no superposition of the radiograph. So the central ray must be perpendicular to the IR at the midway of the glabella and occipital protuberance or inion for 2 inches to 5 centimeter above the
Action.
The central ray must be perpendicular to the IR and centered the midway between the glabella and occipital protuberance or inion 2 inches or 5 centimeter above the external acoustic meatus. So that will be the position of our central ray. The IR, always remember that the IR must be centered to the central ray. Collimate closely on 4 sides to the outer margins of the skull. Then put the markers on the side of the exposure. So we need to put the mark. That's our marker. So that will be our exposure field. Then for anatomy evaluation, the intercranium and upper cervical region are demonstrated. No rotation is evidenced by superimposed rami of the mandible, orbital rods, and greater and lesser wings of the sphenoid. The sila turcica and clavus are demonstrated in profile without rotation. There should be no motion as evidenced by sharp margins of the bony structures. The penetration and exposure are sufficient to visualize the parietal region and lateral view outline of the sila turcica without overexposing the perimeter margins of the skull. So that will be our that concludes our lateral projection of the pediatric patient. Good afternoon, ma'am. I am your radiologic technologist for today, and my name is JONALD ICOY. So, ma'am, imong pangalan, ma'am? Unsay pangalan galing mo, ma'am?
Melanie Sinso.
Unsay imong paano, ma'am? Chest X-ray ba ni, ma'am? Okay. Then, ma'am, before ta mo ato sa ato ang X-ray room, ma'am, pakitanggal tanan sa imuhang mga borloloys sama sa mga necklace, mga metallic objects na imong ginasuot, ma'am, para dili na ta magbalik-balik o expose sa imuhang, ma'am. So, sige, ma'am, naapod tay patient gown, ma'am. So, pwede nimo siya kuan, ma'am, pwede po ta ka i-assist, ma'am, para masuot sa pagsuot sa patient gown. Okay. Today we will going to demonstrate the PHS radiogram of a geriatric patient. So, the clinical indications for this procedure is to demonstrate, to visualize if there is any pathologies on the lungs and the bony structures of the ribs and the cerebrum as well. So, the technical factors that we're going to use is a minimum SID of 72 inches or 183 centimeter, and the IR size that we're going to use is 35 by 43 centimeter or 14 by 17 inches. Then it can be positioned in a lengthwise or crosswise position. So we will going to use a grid for this one, this examination. Then always remember to shield the radiosensitive tissues outside of the region of interest. So because gonads are one of the most radiosensitive of radiosensitive. So in patient positioning, the patient must be positioned in erect, seated, or curled or carved, legs over the edge. Then since today we're going to use we will going to position the patient in a erect position. So the arms around the cassette, instruct the patient that her arms would be around the cassette unless a chest IR device is used, then position as for the ambulatory patient. So ma'am, pakidakos ko sa ma'am, sa IR. Ay sa, ma'am? Sa. Ay, anak mo lang. Ibutang lang sa likod, ma'am. Yes.
Ano lang?
Ma'am, pag mag-expose na ko, ma'am, hinga og lalong, ma'am. Tapos, inhale. Exhale. Pag mag-exhale, pag ma-expose, maingon ako, pag stop na ko kuan, ma'am, mag-ingon ako sa imong, ma'am, na hold your breath, then hold your breath, ma'am, ha. So, in part positioning, ensure that there should be no rotation of the thorax. Then adjust the height of the IR so that the top of the IR is about 1 1/2 to 2 inches or 4 to 5 centimeter above the top of the shoulder, and the central ray is at the thoracic 7. So you can locate the patient's thoracic 7 by palpating his or her inferior angle of the scapula. So, ma'am, touch ka sa mga ma'am ha. So, this is the inferior angle of the scapula. So, you need to center it by since the thoracic 7 and this inferior angle of the scapula is level, so the central ray must be perpendicular to the thoracic 7. So, if possible, image receptor is used because patient cannot be placed up against wall, backy place, pillow, or padding onto the top of the and support the image receptor as shown in this procedure. So, the central ray must be perpendicular to the IR and centered it to the mid-sagittal plane at the level of the thoracic 7, which is 7 to 8 inches or 18 to 20 centimeter just below the vertebra prominence to the inferior angle of the scapula. So, the cassette must be centered to the level of the CR. So, the central ray must be perpendicular to the inferior angle of the scapula. So that would be the central ray must be placed. Then again, instruct the patient. So before exposing the patient, instruct the patient to hold his breath upon the exposing the patient. So the recommended collimation is collimate the area of lung fields. Upper border of the illuminated field should be at the level of the vertebra prominence, which with the divergent rays will result in upper collimation border YR of about 1 1/2 inches or 3.5 centimeter above the apex of the lungs. So again, for respiration, make sure that you will going to expose the patient on the second full inspiration. Then for evaluation criteria, the radiograph should appear similar to ambulatory PHS as described at the patient. So the apices of the lungs the lung apices must be clearly demonstrated. There should be no superimposition of the lung apices, and the claustropenic angles must be clearly demonstrated, and there should be a 9 to 10 read must be clearly seen. And I think that would be all. Good afternoon, ma'am. I am your radiologic technologist for today, ma'am, and I am JONALD ICOY. And ma'am, sige pangalan sa patient? Ano sa birthday niya, ma'am?
January 14.
Ma'am, ang procedure ba nato, ma'am, is chest x-ray on cervical, ma'am? Okay. So, ma'am, natay please, ma'am, na pakitanggal gud sa iyang mga metallic objects, mga borloloys niya, ma'am. And natay patient's gown dito, ma'am. And ang pagsulob sa patient gown, ma'am, is naa sa likod ang paghikot, ma'am, dili sa tubangan, ha. Pwede ko na kay-assist, ma'am, kung para if gusto ka, ma'am. Today we will going to demonstrate the AP projection of the chest for thermal patient, the mobile radiography, and supine in a supine and semi-erect position of the patient. So the clinical indications for this procedure is demonstrate the pathology involving the lungs, diaphragm, and mediastinum. Determining the air fluid levels or pleural effusions requires a completely erect position with a horizontal central ray as in the PA or decubitus chest projection. So the technical factors that we're going to use are the minimum SID of 72 inches or 183 centimeter for semi-erect. Then the IR size must, since our patient is a trauma patient in pediatrics, so we need to use a smaller size of IR, which is 10 by 12 inches. So the grid must be used due to higher KB. The use of grid is strongly recommended since we're going to use a higher KB for this. Always remember that to shield the gonads of the patients because that is radiosensitive. So, in patient positioning, position the patient in a supine on cart. If possible, the head end of the cart or bed should be raised into a semi-erect position. So, roll patient's shoulders forward by rotating the arms medially or internally. So, in part position, place the IR under the behind the patient, then align the center of the IR to the central ray of the IR about 1 1/2 inches or 4 to 5 centimeters above the shoulders. Then center the patient to the CR and IR and check by viewing patient from the top near the tube position. Then instruct the patient to move his hand at the side so that it will not superimpose and chin upward so that the lung abscess will be clearly demonstrated. In central ray must be the central ray must be angled cowded to the perpendicular to long axis of the sternum, which is generally requires a 5 degrees cowded angle to prevent the clavicles of the obscuring the abscess. Since we will use a supine, so we will not use the 5 degrees angle cowded. So if the patient is in semi-erect, we will use a 5 degrees cauda angle. Then the central ray must be centered to the level of the thoracic 7, which is 3 to 4 inches or 8 to 10 centimeters below the jugular notch. So the jugular notch are located at the 3 to 4 inches at the 2 inches below the neck. This one is jugular notch. So the central ray must be perpendicular to the must be centered at the thoracic 7. So in respiration, make sure that you instruct the patient correctly and make sure that before exposing, expose the patient at the end of the second full inspiration. So in evaluation criteria, the usual evaluation criteria for chest radiographs taken in a supine or semi-erect position should be similar to criteria for PA projection described at the earlier video demonstration. So the heart appears larger as a result of increased magnification from a shorter SID and increased OID of the heart. Since we use an AP projection of the chest X-rays, there should be a magnification of the heart. Then the possible pleural effusion for this type of patient often obscure the vascular lung markings compared with fully erect position. Then the PA chest projection. Without the horizontal beam, fluid levels may not be demonstrated. Usually, the inspiration is not as full and only 8 or 9 posterior ribs are visualized above the diaphragm. Then the lungs appear more dense because they are not as fully aerated. The correct CR angle, there should be the 3 posterior ribs should be seen above the clavicles, indicating an obscured apical vision. So the next projection that we will going to use, I will going to demonstrate, is the AP axial projection of the cervical of the patient. So the clinical indications for this procedure is the pathology that involving the mid and lower cervical spine, which is the cervical 3 to cervical 7. Demonstrate that the tubular fractures, compression fractures, and herniated nucleus pulposus or HNP. The technical factors that we're going to demonstrate is the minimum SID of 40 inches or 102 centimeters. the IR size must be 8 by 10 inches since our patient is a pediatric. Then the IR must be in a lengthwise position. Grade should be used in this procedure. Then always remember to shield the gonads of the patient because that is a radius sensitive part. Then in patient positioning, position the patient in a supine or erect position. So in today's video, we're going to use the supine position. Then the part positioning, align the mid-sagittal plane to the central ray and midline of the table and IR, and adjust the head so that in a line from lower margin of the upper incision to the base of the skull or the mastoid tips is perpendicular to the table, and for the IR line from tip of the mandible to the base of the skull should be parallel to angle the CR, and ensure that there should be no rotation in the patient's head. So, cervical, AP, so that would be the position of our patient. Then, the central ray must be angled at the 15 degrees to 20 degrees cephalad and centered at direct the CR to enter at the level of the lower margin of the thyroid cartilage to pass through the cervical 4 and center the IR to the central ray. So that is our central ray. For evaluation and for respiration, suspend respiration, and patient should not swallow during the exposure. So for evaluation criteria for this procedure, the anatomy demonstrated must be the cervical 3 to thoracic 2 vertebral body space between the pedicles and intervertebral disc spaces must be clearly seen. No rotation indicated by spinous process and internoclavicular joints are visible and equidistant from the spinal column of the lateral borders. Then the mandible and the base of the mandible must be the mandible and the base of the skull should superimpose the first 2 cervical vertebrae. Then clear demonstration of soft tissues, margins, and bony margins of the trabecular markings of cervical vertebrae must be clearly demonstrated. So the next position will be the lateral position or horizontal beam of the cervical spine for trauma patient. So in patient positioning, the clinical indications for this procedure is pathology involving the cervical spine, including the Claes-Shuvellers fracture, compression fractures, Hangman's fractures, and odontoid fractures, teardrop burst fractures, and subglue succession. The technical factors that we are going to use in this procedure is an SID of 60 to 72 inches or 152 to 183 centimeter. The IR size that we're going to use is 8 by 10 inches, and it must be in a lengthwise position. So always remember to shield the gonads of the patients because that is very radius sensitive. So in part position, do not manipulate or move the head or the neck of the or remove the cervical collar if present. Then support the IR vertically against the shoulder or place stretcher next to the vertical grid device. Center the IR to the central ray, which should place top of the cassette about 1 to 2 inches, or depress the shoulders of the patient. So depress the patient's shoulder of the patient. Then and the central ray must be perpendicular to the IR. So you must, in exposing the patient, put an IR here. So that will be our IR, and this will be our our markings. Again, the central ray must be perpendicular to the IR of the patient. The central ray must be perpendicular, or the direct central ray must be horizontally to the cervical 4 at the level of the upper margin of the thyroid cartilage. So, in respiration, suspend respiration on full expiration for maximum shoulder depression. So, in anatomy, that will be our central ray. For in anatomy evaluation, the cervical vertebral bodies, intervertebral joint spaces, articular pillars, spinous processes, and zygapicial joints must be clearly demonstrated. The cervical 1 through the cervical 7 to thoracic 1 intervertebral joint spaces are clearly seen. If the upper margin of the thoracic 1 is not demonstrated, additional images such as the cervico-thoracic lateral should be obtained, and there should be a clear demonstration of the soft tissue margins and of the bony margins and trabecular markings of cervical vertebrae, and there should be no motions that can be seen on the radiograph. So that ends our procedure for today.